thank you to our audience for joining us today. I'm Simon Qasir. I'm Chief Revenue Officer and Board Director for Radar Healthcare, and I'm delighted to be joined by some very interesting guests whom will introduce themselves shortly, and they make up a very learned panel. And today's webinar is set to be an insightful session focusing on the practical strategies and real-world insights in how to prepare and navigate the new CQC single assessment framework. Judging from the sign-ups to our webinar today, which is the most we've ever had, it seems that lots of you are joining our webinar today to learn about this highly topical subject. So Antony, could I start with yourself and just give us a brief introduction to who you are? I'll then go to you, Mark, and then to Lal. So Antony, would you mind kicking us off?
Yeah, thank you, Simon, and good morning, everyone. My name is Antony Hall. I'm the Director of Insights Assurance and Governance at HC1, but I'm also the nominated individual with CQC, and I spent 11 years at CQC before I joined HC1 4 years ago. Thank
you, Antony. And Mark, can I go to you?
You can. Morning, everyone. I'm Fewster. I'm the Chief Product Officer at Radar Healthcare.
Thank you, Mark. And Lal, last but not least.
Hi, good morning, everyone. My name is Lal Mangla. I'm the General Manager at Atmos Range HC1 Home in Chelmsford. I've been in the home nearly completed 20 years and being a home manager for more than 12 years.
Great. Thank you, Lal. Thank you all. As a member of the Radar Healthcare sales team, I, along with my team, often have a ringside seat in listening to the challenges, anxieties, and sometimes fears from a wide plethora of different health and social care organisations right up and down the country. We often have a really enviable position where we get to listen to firsthand what are the most recent challenges faced by the industry today. And it's probably no surprise to you that the new single assessment framework that was released by the CQC has probably caused quite a bit of concern amongst some of you, and has probably prompted why so many of you have joined today. And the idea of today's session is to help us demystify some of that. And in order to do that, there's probably different levels of understanding in our audience as to what the single assessment framework is. So as an ex-CQC inspector, Antony, and now part of the Europe's largest care operation, how have you managed the new introduced challenges by the CQC, and what do they mean? So can we start with the what? What are these new changes with the single assessment framework?
Thanks, Simon. And if I just can beg everybody's indulgence to spend a couple of minutes just highlighting the key changes. And as Simon said, I'm sure many of you are very familiar with these, but so the first thing is to say that this is a single assessment framework. Now, why is that terminology quite important? Well, that's important because, as you will know, and from many of the varied sectors that are represented in this audience today, is that CQC had different assessment frameworks for different provider types. So, for example, dentists, GPs, NHS trusts, mental health trusts, slimming clinics, etc., would all have had a separate set of assessment frameworks, colloquially known as the CLOEs, the key lines of inquiry. And the idea is to now assess everybody by the same single assessment framework. And the idea behind that, just so the context is really clear, is that it is to promote integration and promote quality from all parts of the sector. So that if, for example, in my area, a care home is being judged about how it works with the GP practice, the GP practice is also being judged about how it works with the care provider. So the idea is then to stimulate and promote improvement across the sector as a whole. One of the key features that obviously you'll be very much aware of is the move away from what was known as an inspect and rate situation to now an assessment and ongoing monitoring. So, as you know, the whole inspection regime from CQC was based around over the threshold inspections. And actually the regulations were set out that you could only re-rate a service if you actually stepped over the threshold and conduct an inspection event. Now, that still is the same, but now we also have the possibility, and some may call it a challenge, but some may also call it a great opportunity to have our ratings changed more in a more agile way through desktop assessment or monitoring. And that's not new in CQC. We were kind of doing that in GP practices several years ago, but actually weren't able to re-rate because the regulations wouldn't allow us to do that. So that presents challenges, and it also presents opportunities. And I think the other bit that's a very significant change is obviously you'll be used to, in the old inspection regime, a set of ratings that are determined by a set of characteristics that could be applied, sometimes somewhat subjectively by inspectors, around what the definition of good, it requires improvement, outstanding, inadequate was for certain elements. And now we have a set of quality statements which are now scored, and they're scored against a set of evidence categories. So the 5 key questions remain: the safe, caring, responsive and well-led and effective. And what sits below them is slightly different. We have 34 quality statements, and each of those quality statements is assessed by a number of evidence categories and then scored, and the percentages arrive to derive at a rating. And the scoring system is actually quite simple. It seems complex at first, but there's many tools available, and you'll hear about one later today that will help us get to that scoring. I think to sum up the changes as well, I think it's important to recognise that the evidence categories that will actually be used to assess and score the quality statements are quite a significant shift. So there are 6 evidence categories, and out of the 6, 3 of them are around experience and feedback. So the experience of people who are using the services, the feedback from the people who are using the services and the colleagues in the homes and other services, and also the feedback from all of our stakeholders, whether that be in the primary or secondary care arena, or all the kind of periphery around health and social care, and also external partner agencies, Age UK, for example, Health Watch, etc. And that's quite a significant shift for me, because whilst as an inspector and as a person that used to review a lot of reports, I would have found that people's feedback and their views on their experience certainly provided context around regulatory judgment. Now, 3/6 of the whole evidence categories is based exactly around feedback and experience. That's a very, very significant shift. And the fact that it is now scored is a very different situation. Then the other 3 evidence categories, of which only 2 apply to social care, is around processes, and that's very specific about incidents, near misses, which obviously radar healthcare plays a big part with, but also duty of candour and learning. And then we have observation, and observation is now right at the heart of the new assessment model, and quite rightly so, in my opinion, about how we just sit and observe about staff practice, their culture, the way they deliver health and care. And I think finally, for the health sector, but not social care, there's also a 6th evidence category around outcomes for people. So that seems to me as really quite a critical bit about how we capture and how we actually demonstrate our ability to meet the new framework. And I think my final point, Simon, if I may, is just that right through the quality statements, right through the evidence categories, you'll find a word that keeps reoccurring, and it's learning. There's a real emphasis throughout this whole framework about being a learning organisation. The first quality statement in SAFE is about learning culture. One of the quality statements in well-led is about how you learn and improve. And it's about how you capture all the learning from things that go well, not so well, or horribly wrong, and you learn and improve, and you can demonstrate that sustainable improvement. And I think that gives us some great opportunities to demonstrate how we can learn as organisations, which has been the whole emphasis, particularly in the health sector and more recently in social care, for the last couple of years.
Great, Antony. Thank you very much for that very detailed explanation of the changes that have occurred. One of the things that you mentioned there around this being an opportunity, I had a conversation with Mark Fewster several months ago when we learned that this was going to be quite a seismic change within the industry. And Mark, I'd like to bring you in now. When radar when we learned about the new single assessment framework, and the idea that the CQC were going to be have a greater reliance on data, that as a chief product officer, that must have definitely excited you. In terms of where you envisage from a technical standpoint how radar could assist, and Olivia's kindly put onto the screen a dashboard that you're the brainchild of. Would you mind just describing to our audience what was your thought process when it came to what opportunities that could offer with the single assessment framework, framing it as, we already had, for example, an event type called mock inspections. So for you, it probably wasn't that big a leap in gathering data in this manner. But I'm sure our audience would love to hear your thought process as to what the technical challenges were and how you have come up with this dashboard.
Yeah, sure. I mean, it wasn't so much technical challenges, to be fair. It was more almost reflecting on Antony's point. So we've always, as radar, captured evidence associated with CQC inspections from the incidents that are happening, policies, documents, workforce compliance, all the elements that radar does as a product. I think for me, coming into this as not necessarily a subject matter expert, but coming in from a technical point of view, I think the first challenge was an understanding challenge. So actually trying to, again, reflecting on what Antony was saying, just what are the actual changes here? What do they mean to the people who are having to kind of evidence against this? And again, speaking to Antony's points, the standout, other than the mechanisms and how the scoring works and all that stuff, the standout is actually the feedback. So actually, the way that the evidence is now going to be gathered, feedback from staff and leaders, people's experiences, feedback from partners, observations. So we do that. We did that within radar. So obviously we've got complaints, feedback mechanisms within the product. What we've built out or looking to build out is actually how do we, especially with the remote inspections and the desktop inspections, as Antony said, how do we make sure that our product enables you in the audience to really simply and effectively get your hands on the evidence that you're capturing within the system? So there are this is one of them. So this is basically a mock CQC score for a single care home. But behind these, and I think we're going to do the demo on the next session, to be fair, but behind these, it would be where you're capturing your feedback and learning. So that could be feedbacks from friends and family, it could be complaints, could be compliments, could be excellence reporting, could be the observation. So again, one of the things that we're building out at Radar is a new observation event. So to Antony's point, how do you allow third parties, family members, staff members in care, or the residents perhaps, to be giving observations there and allowing you to capture that information? And then sitting across all of this, how do we give you the ability to be able to evidence the learnings from all of the different feedback elements, all of the events and the audits, etc., that you might be capturing? So naively, almost for me, when I first looked at it, I thought it might be just really simple. We might just have to build a new Chloe audit. But actually digging under the surface of it and actually getting under the skin, speaking to people like Antony, it is transformational in terms of the change. And it's much more around how do we make sure that you've got access to the feedback in a way that's easy to capture, easy for individuals to fill in, easy to report on, but probably more importantly, easy for you to understand how to drive change and action from the data that we're capturing.
Yeah, thank you, Mark. One of the things that was quite enlightening for me when we all got round a table and had this conversation about what are the key changes. Antony, I'm going to come across to you, Lal, shortly to describe a real life inspection that has taken place underneath the new single assessment framework. But before doing that, Antony, can I just bring you back in and just describe from a HC1 perspective? I know you guys took the bull by the horns quite early and designed, in essence, a workbook that was then pushed out to colleagues across the organization. Could you just describe your strategy and how you brought colleagues up to speed with the change and how you manage that internally?
Yeah, so I think this is a really important point, because I'm keen to stress that 5 years ago the whole CQC inspection regime was right at the heart of service managers, whatever service type they are, and providers. It was something we dealt with constantly. And we built up mechanisms in all our different providers and all our service types to demonstrate that evidence. And we had evidence folders, we might have had various systems, and et cetera, et cetera. And we were all geared up for that. And then COVID happened, and then CQC kind of moved into the risk-based inspection format. And a lot of that emphasis has gone now. And equally, particularly in our environment, where there's been quite high turnover of staff during COVID, is that actually there are people working in our services who've no real experience of a CQC inspection, or of certainly never prepared evidence for them. So we felt quite strongly, we've actually face-to-face done workshops with every one of our home managers and and the team that surrounds that, around about 500 people over the last month or so, to socialize what the framework means and the mechanics of it, how the scoring works, how the quality statement work, how the evidence categories work. But then more about that, it's about giving people some material for how then you start to build up the evidence. And because for some people, this is new. But even the people that were familiar with the old CQC inspection approach are not familiar with how to capture feedback effectively. And some of that feedback is quite systematic. So, you know, all of us as providers will have feedback mechanisms and maybe systems that do that to capture feedback. And there's always the traditional survey kind of approaches and all that kind of stuff. But actually, it's the ad hoc stuff. It's the person who comes into your service. For example, a primary care practitioner coming into one of our homes, for example, who makes some comments that are really positive or negative. And it's how do we capture that and do our learning from that that's new and needs to be right at the forefront of people's minds. And so is observation. I'm always gobsmacked about how few people do observations in their services, whatever type of service it is. Just sit for half an hour and watch. Because that's how we used to train CQC inspectors, is to watch and listen and smell and see what you do. That's what observation is. How do your staff interact with service users and other people around that service? So I think that's, so we've prepared this kind of workbook that for each one of our services that in England, that allows people to look at that and allows them to start building that evidence. But obviously will then be built on when we introduce the CQC dashboard from Radar.
Yeah, great, Anthony. Yeah, thank you for that insight. I'm sure it's valuable to other organisations that are on our audience today to hear what another organisation may have done. I'll come to you, Lal, in a second. Before doing so, just a reminder to our audience that if you do wish to participate, please do add any questions that you may have or any comments that you may have into the chat area, and Olivia will be monitoring that and feeding that to us shortly. Lal, do you mind if I come to you now? Now, Lal is a registered manager for Admiral's Reach Care Home, a 128-bed care home in Chelmsford. And recently, Lal, you went through the new inspection framework. So this might be very interesting to some of our care managers or deputy managers that might be in our audience today, to hear a real life example of someone going through the new framework, going through the inspection. What were the key learnings that you found? And ultimately, I believe you've also got your results now as well. So Lal, can you give us your insight? What did you learn from this?
Yeah, fine. Good morning, all. I hope you can all hear me.
Yeah, we can hear you.
We had the inspection for 2 days in January. That is on the 24th and 31st. And there was 5 inspectors, 5 people who came in, and that was the lead inspector and the associated inspector. And there were 2 people by experience, and there was 1 specialist nurse advisor. They have gone around and then spoke to people and then gathered most of the thing. I'm going to highlight 5 key area in here. As Anthony said, again, you may be getting bored, but this is the important bit. Feedback, experience of people, observation, communication, learning, and lessons learned. That is where we need to be shifting our view in other hand, because before the inspectors comes, most of the time they spend in the building with you or most of the paperwork. Now they will introduce yourself. They will ask you the questions, what is required and what is for the day. And they will give you a brief account of what they have been doing for the day. And they will go out to speak to as many as residents, relatives, any visitors, any external professionals. And their feedback on the day, it is valid and it's been making the mark for you on the day. I would say 60 to 70% involve the feedback and experience of the people. And they would like to see that transpired on your records and record keeping. When they speak to someone, they will automatically, they're going to take those folders, who they spoke to. And that is what they want to identify and verify to see that you are providing the right care and everybody understands and everybody know about the details of the resident. And the one comment which they have been said, I know it need quite a lot of coaching and continuous observation. In other hand, as Antony said, you have to be on the floor, or your designated person needs to be on the floor to observe before they comes in, go for a half day or do half an hour to 1 hour mealtime experience. That is a good thing which you can see how the television operates, how the radio operates, how the interaction operates, how people does it, how people communicate, how the special needs diet requirement has been met for the people, and the choices are being provided. Have they been constantly communicating, even though they do have the condition of dementia or non-dementia, how the distress and behavior which is being managed. Those are the things which they will be looking onto it. And the feedback, it has been really, really important in the sense I did had 2 externals on the second day. One was the DIS team and one was the DN, district nurse, who has been visiting. They have given brilliant feedback. Mine, the day has gone very well, 2 days. And and the staff needs to be a bit more relaxed. And one of the comments which they have been said, the CQC inspector, I think it really highlights on me. The staff was not doing because they were standing there. They were more relaxed. They were attention to detail, and they were doing it as naturally. It takes time. I totally understand with your mix of staff or the skill mix or the people who's been newly joined or the people who's been there for many years. We need to do some training, coaching, and the preparation. If we do that, then that'll be great. And on the day which they are being given the full feedback, and within 2 weeks, they have sent me the feedback related to 5 areas, which is safe, effective, caring, responsive, and well-led. And then followed by that, this 7th week, I received the factual accuracy report. And then we responded on the same day or that week itself. And 8th week, the report has been published. Right. And I was pleased to say that every area which they have been scored, the slide which they have been shown, if you mark every area as 3 and above, then you will see all good. And I've achieved all 5 areas in good, and I was really pleased to see the outcome.
Oh, well done, Lal.
And one more thing which I need to add is they will ask, how are you going to be promoting independent choice and control? They will ask those questions, and be prepared for 2 or 3, even 5 residents on your agenda for the day, or anyone and everyone. They also can speak to the person in charge on the community. Plus, you can also explain, and they will definitely ask you. I've got a lady who came as on a peg, immobile, fully bedbound, and nil by mouth. Now she is out of peg, and she is been riding an electric wheelchair, and she is eating and drinking as normal like you and me. And that was my testimony to explain. And they went and then spoke to that resident, and they spent quite some time. And any kind of that, please do bear in mind, 2 to 3 people you need to be exampled, and then you can prove that. And they will also check those care documentation in our hands.
Well, thank you very much, Lal. That's an excellent insight, I think. I could ask you several more questions, but I'm conscious of our time, Olivia, so please do keep me on track. One of the things that I did want to mention to our audience, that this is part 1 of a two-part series. We have a follow-up session, which is navigating the path to sustainable excellence under the new CQC framework with Radar Healthcare. And that next session will be on June the 13th, I believe, Olivia, if I've got that right, June the 13th. So if you wish to sign up and you find this first session insightful, then please do join us for the next session, which will be on the 13th at 2 p.m. next month. And we'll be providing greater insight at that point, particularly around Radar's Healthcare's response to how we can help our customers and potential customers navigate the new single assessment framework. Let me pause here, Olivia, and just again offering the interaction to our audience. Do we have any questions or anything that anyone wishes to raise?
Yeah, so if anyone does have a question, please do type it into the Q&A functionality, because mics and cameras are not enabled. So I've just seen a few hands go up. So if you do just want to type the question into the Q&A, and then we can pick that up.
Great. Thank you, Olivia. Whilst we're doing that, and we're waiting for people to type in a question, Lal, do you mind if I return to you? And I just want to pick up on a point that you made around coaching. For staff members, frontline people, and getting and the CQC inspectorate asking for feedback. How did you go about coaching and training your teams around the new framework and what to look out for? Obviously, now with the benefit of hindsight, because you've gone through that process, do you have any advice or any additional advice to any of our audience on how to do that for frontline carers?
Yeah, I would say we do have, as a company, we do have the e-learning and specific training associated with, including the CQC framework for the senior staff, and they go to do those trainings, and those trainings we need to be applying onto the floor. What we rather ask when we do the walk around or stuff, for example, for IPC, we will ask them specific questions. How you do the donning and doffing? How many steps of hand washing? Those are the questions which we need to be asking. Those are basic questions, nothing to be afraid to ask, or nothing to be training and coaching them, the staff, because they need to get that confident to speak to the inspectors, and that's what they wish to see. And if you start doing those kind of practices, you ask them the question, then they will answer. If anything, then you correct. And you can do a small session of group supervision kind of thing, and in a meeting or in a session in the afternoon. I do have a clinical services manager and clinical lead, which we constantly do that. And right. That is the only way which we need to be checking their knowledge and then transferring that knowledge into them. It's a two-way conversation rather than one-way conversation.
And
great practical advice.
Simon, can I just come in just for
please, Antony?
Well, just to add, because obviously what we've just been referencing there is very specific to social care, and I'm keen to point out that all of these things that we've been talking about are completely transferable to the rest of the health and social care economy, because it's the same framework. So I was telling Simon last week that I've been doing some work with the primary care network that in my local area about preparing their GP practices in exactly the same way that Lal's described, about feedback, about the experience giving people, about how to demonstrate the care that we give, whether it's in the health sector or the care sector, to a CQC team. So so I'm eager to point out that even though we're giving very specific social care examples here, this is completely transferable, and it's because it's the same framework, and that's really important to recognize.
Great, very lucid point. Thank you, Antony. Olivia, can I pause there and see if our audience has any questions for our distinguished panel?
Yeah, so we have a few questions coming in now, so thank you, everyone. So we'll go to Erica first. So how have people best captured the voice of those who don't use words, apart from feedback from families and observations? We have created a tool, but wondering if we have missed anything others are doing.
Yes, good question. Antony, could I start with you on that?
Well, I mean, I think this is a fascinating area, and I think we could talk for several hours on this one. I think that I doubt you have missed anything, Erica, by the fact that you've even gone through the thought process of creating a tool. I mean, this is a real challenge for us, isn't it? And it's a challenge actually for CQC in order to gain the voice of those people as well. And I think we can use that through, you know, some sort of pictures, through imaging, through the way that we work with dementia communities to try and understand people's views. But for me as well, it's the family, as you referenced quite rightly there, plays a significant part. But I certainly know for CQC, the way they've been preparing to deal with that challenge is through the observation. So they're going to look at the interaction through observation, whether they use a formal SOFI tool or just, you know, on the piece of paper. They're looking at those interactions and they're looking at whether that changes people's mood states and whether that's a positive interaction as a way of capturing that voice. But a fascinating question that I'm sure we could pick up for several hours afterwards. But thank you.
It's a great question. Mark, any further thoughts on how from a technical standpoint or a product standpoint we would manage that?
Yeah, I mean, to Antony's point, we've also gone down the route of the observation being that mechanism. What I would say though is if there are other mechanisms or you are capturing data in different ways, that information can still flow into Radar in the sense of being that aggregator of your evidence again. So if you've got different methods of capturing data, different systems even, we can bring that into the product as well.
Yeah, fantastic. One of the things I think we have an audience where we've got lots of people using Radar at the moment, Mark, and I'm sure the teaser of the dashboard view that we put up on screen and showed. Could you perhaps give us a bit of insight into how that came about? What are the challenges of creating such a dashboard? I do know that from our Radar Healthcare's response, this is going to be a free dashboard that we provide to our customers in response to the single assessment framework, and it's probably an evolution of that pre-inspection event type that we created some time ago. And maybe could you also cover the time frames associated and release? I know it's the dreaded question, Bob, but you know I'm going to ask it.
You asked it on the chat as well. I mean, to reiterate your points there, Simon. So the CQC event and the CQC dashboard will be free, as will the observation event and the observations dashboard. To Erica's question, there's no cost to either of those. And the CQC dashboard we expect to be available by the end of this month. The observation one might take a little bit longer because we're trying to evolve it, working with people like Antony to just make sure we're fine-tuning how we're capturing some of that data. I mean, in terms of the evolution of it, if you flick back to the screen, actually, Olivia, if that's okay.
Oh, wrong way, sorry.
No, it's okay. Again, it was, and this may again evolve. So again, if your customers have Radar, hopefully you're aware of how we develop the product and how we work with you, the customers. Of actually, this will evolve based on the feedback that you're going to give us once you've got your hands on it. So it might look like this now, 6 months time, it might look completely different. But the principle behind it, as I said, rolling back to what we talked about at the start with myself and Antony, to be able to give you an easy, in inverted commas, way to have that evidence, learning, observations in a single place where it's accessible. In this case, we're looking at a single care home for sort of the care home manager in this particular example. But again, this could translate, again, to Antony's point, across any kind of healthcare environment. It's just around how are you making sure that you're, again, if you're using Radar, things like tagging and the audits that you might be doing, the events that you might have, the policies you might have, the training, how are you connecting those up into these different we statements? And then these dashboards sit over the top of that, and in essence, just give you that rapid access to that information. Genuinely, our ideal world would be the CQC could just come in and say, right, okay, look at the dashboard, go through, and then they're able to see the evidence and the information that you've been captured, using Radar. Our vision, if it would be something that could be done, would be actually, a mechanism for the CQC to just go in and look at the evidence that you're allowing them to access, if that makes sense. So that's the longer term vision and the kind of concepts behind it.
Yeah, I remember having this conversation with you, Mark, and Antony, actually, when we were in Leeds at the head office. And one of the things that we recognise is that organisations up and down the country that are providing really good quality care to lots of people quite often are not in a position to be able to evidence that. Anecdotally, we know that they're delivering really good quality care, but can they really evidence it? And I suppose our starting point was, could we create a dashboard to provide that evidence, to show the quality of that care that's being delivered in that environment? And that was the starting point to this entire conversation. So beyond what just the CQC want from a single assessment framework, I think from a radar perspective, we wanted the ability to show that on a single dashboard, how an organization could provide evidence of the quality of care that they're delivering and areas that they may need to look at. And I'll just pause before I go into the lessons learned dashboard for a second. Olivia, do you have any other questions that you want us to cover off? We've got still some time to take some.
Yeah, so probably just a relevant question to cover. So a question from Kate, just to say this is very helpful. Great work. Do you have any plans to do a similar dashboard for other nations? Is that in plan, Mark?
It's a really good point.
So this concept can just be transferred to anywhere, Olivia and Kate, I think it was who asked the original question. So we can build the standard dashboards as we're doing here and the standard events that drive behind this. The bit we've not touched on is you actually, as a customer, if you've got the license for our analytics, you can kind of construct your own based on these templates as well. So if you've got a slightly different version of this, if there are particular things that you're interested in, if you want to kind of change the views, change the design, again, you know, as a customer, you're able to configure these to meet your requirements as well.
And I think if I can just build on that, because as a provider, we've got 54 services in Scotland, so we're quite mindful, and we have services in Wales also, but we're really mindful about meeting the needs of the care inspectorate in Scotland. And actually, notwithstanding what Mark said about the configurability of these dashboards to meet that, I think one thing to recognise is that, in my view, the new framework for CQC brings it a lot closer to the Scottish framework and the care standards, because the care standards have always been about promoting autonomy and independence around an individual and their rights and their human rights, as well as listening to their voices and the involvement in them in their planning of care. So if you compare the care standards in Scotland to the new framework, and I know it's a social care overlay, but they're a lot closer than they've ever been.
More aligned.
So it's important that the dashboard can be configured, but actually the framework itself brings it closer.
Yeah, understood. And even further afield than Scotland, I believe in Qatar, Mark, we're putting something similar together based on this too. So yes, it's transferable. Kate, Olivia, do we have any other questions from our audience?
Yes, we do. So we've got a question from Michael. Did CQC request information before the visit, and did they expect your own evidence or feedback from staff, patients, etc.?
Great. I'll go to Lal for this, if I may.
Yes, they have not beforehand. On the following the first day, depending upon what evidence they ask, if you don't produce it, they will give you a time scale for you to send it across. But they won't give you any glimpse before they come out. That's for sure. And they will follow it up with followed by the first day of the visit. They will follow it up with the email if they request anything, if you're not able to provide on the day.
Got it. Okay, thank you. I hope that helps.
Thank you. And another question, is there any advice for observations with digital healthcare providers, please, and how can this be demonstrated?
Mark.
I think we'll probably cover that in the next session where we're doing the full demo. So there's a few questions around kind of sharing the dashboards and having an app. I think in that, sorry, Olivia, I forgot the date. Was it the 14th of June?
No, 13th of June.
Yeah.
I think on that session, we'll do a full end-to-end demo to show you how all of this joins up.
Yeah, that would be great, Mark. I'm sure, you know, this teaser that we've provided on screen is probably opening up quite a number of questions by particularly radar users. So yeah, I think a full demo on the next session would be of great value.
Yeah, and thank you. There's just a couple of questions about the recording of this webinar, so it will be shared early next week. So do look out for that if you are wanting to share with your colleagues that were unable to make today. I did just see a hand go up, so if there is any last questions, pop them in the chat. If not, I think we've covered most for now. Simon?
Yeah.
No, sorry, Libby. Around, will the CQC dashboard be pulled from an event or an audit? So this dashboard is from an event. The evidence, the observations, the feedback and learning will be from all over Radar. So it could be from the policies, it could be from the audits, it could be from the events. The aim is to kind of have consistent, being a Radar customer, a workflow step in there to kind of capture that data, which again we can go through on the demo on the next session.
Great, Mark, thank you. Whilst we wait for a few more questions, I wouldn't mind touching with you, Antony and Mark, on a dashboard that you are creating, and Antony, you provide a great deal of insight for, called Lessons Learned. And I'll start with you, Antony, because this was a specific dashboard that we designed for HC1 initially. And then, Mark, you've incorporated that now as part of this CQC dashboard. But Antony, give us your thought process. What was the idea, and what really resonated with me on this point, if I may start with, is when you look at a screen like this, to lots of people that looks like data. And that's almost a swear word to you, Antony, because you don't like the word data, you like the word information. Yeah. And I think the difference between that is quite subtle but profound. And that is, when you mention the word data, to lots of people that conjures up technology, whereas what you wanted to do was drift away as much as possible from the tech aspect to the actually, how can we read the information that's presented to us on screen and then make quality decisions? So if I may start from that context.
Yeah, thanks, Simon. And it links to the learning dashboard quite significantly, I think, is because when we first introduced Radar, one of our requirements was to not push out reports to people anymore, not give hard kind of KPI kind of data, but actually put in the hands of the people who actually run the service all the information they need, so they can join the dots, because actually they are the people that can make the improvements, not people like me sat 200 miles away. So I think, so and it's a real shift about giving people information as opposed to data. As you say, data to me has a connotation of a spreadsheet that's going to come out and it's going to tell me what to do or tell me what's wrong, or and it might be RAG rated and all that kind of stuff. And actually information is something different. It's about giving dashboards to people who can then use that information in the way that they need to in the service that they provide. And one of the things, and that links to learning. So to your first question, was that, to me, the important thing when we introduced Radar around events was not the incident recording and what went wrong, why it went wrong, or what went right and why did it go so right, and all the categories. That is important, and it's important pieces of information. But actually the most important thing for me was the learning outcome. And because without that learning outcome, you can't possibly hope to improve. Now, we've got a real opportunity, given the size of our company, is that we can learn on a huge scale, but it doesn't matter what scale you are, you can continually learn. So we built a learning the lessons dashboard, we call it, a learning dashboard, that actually at each service level, but then at each kind of geographical regional level, and then across the whole company, we've got established pieces of learning that have come out of those events that we can then share through our organization in something we call a learning meeting in our services.
Right.
And we look at that learning and we truly try and learn so that we prevent those incidents happening again. And then Radar becomes the measure of that, because you would hope to see the repetition of similar incidents reduce over time.
Yeah, great. And then that presented another opportunity from a product standpoint to you, and Mark, when we designed the dashboards for HC1, you then incorporated that within this particular dashboard, which we're not showing fully at the moment, I appreciate, but just give us your thought process as to what opportunity did that lead to.
I mean, it's similar to what Antony said. So what we want to create is basically a mechanism to allow those learnings to be surfaced as easily as possible. So typically being captured from an event or possibly an audit. And then they might exist at different levels in terms of the organisation hierarchy. I think taking it a step forward, what we're trying to do with a lot of the things we're talking about here, but more importantly, the learnings, the way we've created the mechanism is if, and this is kind of, more so to the customers, the space we're creating within the community outside the physical product of actually how do we create a space where those learnings can be shared across organizations as well. So we've tried to create some consistency in terms of the method of how we're capturing that to be able to populate the dashboards for the actual organization, but actually create something that makes it easier for, collectively you as customers or just organizations to be able to share and learn from each other. That's really important to us, of almost saying actually it's not just the physical product of buttons and data and all that kind of good stuff. It's actually the product in the collective of you as customers and you as people who are working with us. So why should the learnings that Antony has not be learnings that are shared widely across the care sector? We want to get rid of those silos as well. So it's part of its dashboard, part of its data, but much more, hopefully, cultural and kind of changing how we think about sharing some of this information as well, which is how we're constructing it. We kind of need you guys to come with us on that, but that's the vision.
Yeah, fantastic, Mark. Thank you. Olivia, any other questions?
So just the one that Mark has actually answered in the chat, but I think it might be worth mentioning to other customers that just around the dashboard being piloted with any of the customers, if you are wanting to get involved, you can do via getting in touch with your CSM or project manager. So yeah, please do contact them. I did just see, sorry, Simon.
Do we want to put that on the community, Mark, some sort of data capture, that if anybody wishes to participate in this and how we're building out these dashboards or to pilot these dashboards, is there a mechanism or are you?
Yeah, so there is already a beta group existing for the CQC. So if you are a customer, you go to the community, there's a group for CQC there which you ask to join. Within that group as well, there's some documentation we've put together, which is our explanation of how the new framework works, including how the maths work and all that kind of good stuff. So yeah, there's some good resources on there.
Okay, fantastic. Thank you, Mark. Antony and Lal, if I may come back to you, one of the things that is interesting, given the fact that we've got this new single assessment framework and some of the key findings that have been identified on this session today, and Antony, from your perspective, where do you see that leading us? Because what is from a you're a large provider, hopefully the aim here is that the people on the ground are going to deliver a better quality of care, and as an organization you're going to be able to evidence that, and one of the tools that you may use is radar. But overall, where do you see this benefiting the sector? I know it's a broad subject and you and I have covered it in the past, but where do you think the benefit lies with the single assessment framework?
Thanks, Simon. So I think we were talking about the single assessment framework when I was still at CQC, which was 4 years ago. So it's not entirely new in its genesis, but I think as the integrated health and social care economy started to come together about 5 or 6 years ago, and it's still kind of manifested itself through ICBs and etc., is it became really clear, I think, to a lot of people inside CQC that we needed to find a way that we provided a stimulus and being a catalyst to improve the sector as a whole. So if, for example, the example I used, a very simple example earlier, was that if a care home is getting a poor service from a GP practice, then where do the incentives for that improvement come? They can only come if everybody's being assessed the same way and about the same experience around that person. Because for me, it's about a journey for people, isn't it? Because I view our residents in our company as actually GPs' patients, because that's what they are. We're all a patient of a GP. So therefore, my experience living in a care home is also molded by the experience I get from my GP. And we can go across that to all kinds of, whether you're sat in a hospice environment, a trust. It's all those interactions around the system as a whole that do need to push and pull so that the levers provide a stimulus for improvement. So I've kind of got this utopian vision, and I really hope I'm right, although I know there's many dissenters out there, that in 2 or 3 years' time, once the framework is applied across all those parts of the sector, we should see an improvement around the patient resident, the person themselves, because that's the focus on everybody in that whole system.
Yeah, absolutely right. Lal, from a service level, what have you learned? So, you know, you've been through the process now. You've got a good rating. What now that you've had time to digest, and perhaps even, you know, the benefit of having a you know, helicopter view on this session today, what have you learned, and that could further improve the ultimate care delivery on a service level?
I have already created a sustainability plan. I think it is the challenge for us to maintain, because it's 2 elements, as Antony said, why they do this single assessment and is the desktop. They're not necessarily come to my service next time. They may just feedback, whatever the feedback which has gone for the GP service, local authority, CCG, or PAM visit, or any visits or external stakeholders, which they've been sending those information, they've been feeding into, and they will do a desktop, and my rating can be changed imminently anytime. And that is one of the criteria which we need to be. So we need to be not to relax, just to keep doing what you have been doing, and a sustainability plan, a robust sustainability plan needs to be created for your service. You know that where it can go back or where it can be sustained, and it needs to be sustained, and then to be achieving outstanding, at least 1 element for next time or 2 elements for next time. It is a hard work. I know it is outstanding. It is real hard work. I need to say we need to be getting outstanding. You need to be projecting out very warm and good.
Yeah, great advice. Thank you, Lal. And Mark, did that prick your ears up, and maybe we create an action plan for this? How do you see that translating into the product? And do you envisage, you know, in the not too distant future, where inspectors don't turn up, you just give them access to a certain dashboard in Radar?
I mean, one more point to close off with, Simon, because I'll take Antony's point, because we had 100% of our residents have been lucky enough with 1 GP surgery registered. Right. And we do every 3 months quarterly meeting, and they also equally inspected. Our feedback has been really relevant for their service when they inspect. The CQC inspect, and the same way. So it is all in partnership. I believe going forward, this multidisciplinary team will work more closely to achieve, from the hospital point, from the community point, from the GP's point, and every angle work together, so they all will get a good rating.
Great, thank you, Lal. Mark, sorry.
I think it's an easy thing from a kind of technology point of view to just go, oh, yeah, wouldn't it be great if the CQC could just log on and get access and see whatever? I mean, I think there's a long way to go to get to that point, but yeah, technically, that's completely possible. I think it's probably the appetite on both sides that would need to have conversations.
Sure. Okay. Olivia, do we have any? I'm just looking at our time. We've got a few minutes left. Do we have any other questions or any points that anyone has raised from our audience?
Yeah, so just on that point, Erica has just mentioned that CQC have asked for direct access to both Radar and Nourish in the past when discussing with local inspectors. However, it hasn't actually ever happened. So that's just an insight shared there.
So, so the challenge has been laid down, Mark.
Challenge accepted. I mean, we can do that now, so we could create something where the CQC should have a view into whatever you allow them access.
For a limited time, is that right? So for a limited period, or just a limited access?
Yeah, limited access, and you maybe give them access to a dashboard and some of the information that sits behind it that they can see, and you don't let them see all the granular details behind. But honestly, I think that's probably a longer term thing. It might be different CQC inspectors are asking for different things. I think that's probably for us to have the conversation with CQC, to be fair.
Absolutely. Olivia, anything else that you want to point out before our session comes to a close and we round up?
Yeah, thank you. So just a final point on registering for the webinar part 2 on the 13th. We will be sending a follow-up after this webinar, and it will have a link where you can register. It is something that you will have to do. There's just been a couple of requests for me to sign them up. So if you can just follow that link, it's dead simple, just to fill out the details and you'll be added to that webinar.
Yeah, fantastic, okay, Olivia, thank you.
Thank you.
And yeah, just on the point about the next session, you know, I know we're laying out a teaser here, and I'll leave you with this cliffhanger. What we want to demonstrate on the next session is the radar's response to some of the things that have been identified in this session today. Mark and his team, the development team at Radar, working with the likes of subject matter experts like Antony and other care operators in our client base, we've come up with what we believe is a very succinct solution for the single assessment framework. We just gave you a view of the dashboard, but actually there's quite a lot behind that we're going to cover off in the next session. And Mark, if you're willing, you're going to be doing a live demo, I believe, and showing our audience the different elements that pull into that dashboard. And we can maybe also touch on the lessons learned dashboard that Antony was talking about.
Yeah, I think it's probably a combination. Again, correct me if I'm wrong, Olivia. I think it's a combination of myself and Antony, kind of just showing the HC1 version, almost showing the Radar version. If that's okay.
That's correct. Yeah, great. Well, let's round this up. It's been incredibly insightful today to talk to yourselves, and thank you very much for the participation of our audience. Antony, final thoughts.
Yeah, thank you. I mean, my final thought is there's a lot of noise about the single assessment framework outside in various networks and various fora. And I think it's important that it is the current framework. So, and whether that will change in the future, who knows? But whatever is, we've now got to look at the opportunities this affords us. Okay, yes, there are some challenges associated with it. But I think HC1, we've got a view that we're going to seize the opportunities that this presents us. The opportunities this presents us, the way that the evidence categories are structured around observation, feedback, and experience, actually allows us to demonstrate what we're all so passionate about, whether we're in the healthcare sector or the social care sector, is about delivering the best possible care. So I think if we embrace that, and we're onto a really good thing, because for the first time, it's less about have we got our fridge temperature logging chart right, and more about is the person getting the right experience and the right health and care experience. So this is the opportunity it affords us. Let's embrace the technology that's been given to us to help us do that. And then ultimately, everybody gets better health and care.
Great, thank you. Just once again, thank you very much for your participation and coming along today, Lal, and sharing your great insight. Mark, always appreciate your thoughts, the thought process that you've put into the product and the direction of travel for our roadmap. And Antony, once again, thank you very much for sharing your insights, and we look forward to the next session. If anybody has any thoughts, any questions around this webinar, please feel free to contact Olivia, myself, the marketing team, Radar team directly, and we look forward to the next session. So thank you very much, everybody. It's been enjoyable.
Thank you, everyone.
Thank you, everyone.
Thank you.